Well, good morning, afternoon, evening, night, wherever you might be. My name is Key Park. I'm the Director of Policy and Advocacy for the program in Global Surgery and Social Change at Harvard Medical School. I'm really delighted to welcome all of you to this Grand Rounds session today. We have an amazing panel ranging from all the way from WHO to academia, patients, families, and advocates from grassroots level in a developing country. And we're going to talk about the importance of connecting policy with advocacy for action. What do we want? We want to improve healthcare for everyone, right? This is health equity, social justice, specifically on neurological conditions. So we have, I just want to introduce two documents which brought this event together, which is, the first one is the WHO's Intersectoral Global Action Plan on Epilepsy and Other Neurological Conditions. This is really the roadmap to strengthen care pathways, prevention, policies that help, that deal with neurological conditions. In addition, our program in Global Surgery, we have developed a product for specifically recommendations for health ministries to manage a specific neurological condition, hydrocephalus and neural tube defects. This is called Comprehensive Policy Recommendations for the Management of Hydrocephalus and Neural Tube Defects in lower and middle income countries. So these are great policy documents, but we want to talk about today the importance of advocacy and getting the things done at the country level, at the ground level, local level. So here we go. I'm going to turn this over to Eddie and Camilla, and I look forward to a great discussion, and thank all the panelists for making the time to be here today. Over to you.
Thank you, Key. I am delighted and honored to be here today and to have the opportunity to listen to our amazing panelists, and hopefully we can have a lively and interesting discussion towards the end of the session. So this is a topic that is very near and dear to my heart. And although I think we as medical professionals often fail to include civil society in advocacy, it is beyond doubt that we as clinicians and researchers, we need the whole spectrum of change agents to actually drive change, right? We need policymakers, we need patients, we need a broad range of medical disciplines such as public health. We need NGOs, relatives, and patients. And as Key said, today we have them all represented. And we plan to discuss advocacy capacity through two entry points. And that is, as Key said, the Intersectoral Global Action Plan and the Chisp document. We call it the Chisp document. It's short for Comprehensive Policy Recommendations for the Management of Spinal bifida and Hydrocephalus in LMICs. So all our panelists will provide rather short 5 minutes presentations, which will give us about 40 minutes in the end for discussion and comments. So if you have any questions or comments, you can raise them towards the end, or you may also write them down in the chat, and Eddie and I will try to manage them as we go along. With that being said, let's just get started. It is a pleasure for me to introduce our first panelist. Dr. Yogi Particippu is a professor of pediatric surgery at the University of Central Florida. He has been chairman and member of numerous professional boards, committees, associations, and societies, such as the International Society for Pediatric Neurosurgery. He is currently co-lead of the policy advocacy team in the Global Neurosurgery Committee, which is part of the World Federation of Neurosurgical Societies. Yogi was instrumental in the creation and the publication of this Chisp document, and with his team, he is now working on the important phase of implementation of these recommendations. He will present on the Chisp document and how and why civil societies are important in the implementations of these recommendations. Yogi, it's all yours.
Thank you, Camilla. Nice introduction, appreciate it. Friends, before I start, just a moment to say it is difficult every day to see the news of the world disaster in Ukraine. Having served there for a few weeks in Dnipropetrovsk, the Children's Hospital, and being with the surgeons in a beautiful place with wonderful people, it is hard. Every day we get tears watching the news and the things that are happening there. Our hearts go out to them, and we pray that things end quickly and hopefully improve soon. Friends, a few things in life warms the heart, like to the core, like knowing Key Park. Nice introduction. My first meeting of Key Park was in 1990, I think. He was just entering neurosurgery at Temple University, and I was leaving as chief of pediatric neurosurgery. A little introduction. So tough does that bond that almost 30 years later, we were sitting in the Harvard PGSSC offices with Ben Worf and Jackie Corley, Ulrich, Sidney, etc. And this document was started. We were working on it. Then, of course, Jacob Lepar, Myron, Dean, Jeff Blount, all these people. And then COVID came, so everything was laid low. So you can go to the next slide if you want to, please, Eddie. So basically, the first thing I was supposed to talk about is the history of this document. That's why I'm going you back to 30 years. And then post-COVID, my dear friend Key tapped me on the shoulder and said, let's take this document that was written, but we need to revamp it to get it and publish it in honor of our dear friend William Harkness, who passed away. So we worked hard on this thing, and a new team came together, and all the old people helped, and we just redid the whole document to put it together in the form that is now usable. It tells you the power of Key Park when he gets a hold of you. Friend, the biggest change that we're able to make, and this goes into the second bullet point of the team, is getting the international flavor. It's not right for people to sit in fancy chairs and offices in various countries and tell other people what to do. So we included, as you see on the list on the far right, 30 plus people from all over the world. And while you're busy reading all those names and lists, that is what made this document. That is the team of global neurosurgical power. There are two major issues we're working on: head injury and spina bifida hydrocephalus. And the other documents, as you hear later, will be addressing the other ones. I'll stick to the CISPR document. We were able to redo the whole thing, and we're fortunate that a document was generated that's been now circulated. But now the biggest part comes is to make it actionable, to make it a better issue. I'm going to take a few minutes to explain the document, what the structure is. So when you look at it, as it's going to be shared with you in the chat or by the emails from the documents of the meetings or the minute meetings, you'll be able to review it. A few of us got together. That includes Colette with her wonderful skills, Camilla, as you just heard, Ahmed from Egypt, and of course, the great Key Park and myself. We worked together for a few weeks and months and redid this document. Next slide, please, sir. These are some clips of what this document and how it's structured. Friends, what it is a beautifully written colored document. It is made to make changes wherever you can in the environment where you are. It has 5 major sections, as you see on the top right, and it goes everywhere from screening to prevention, and of course, what can be done before the patient comes to the hospital and into the system, and the weaknesses and the strengths of any surgical system, and the important piece of rehabilitation, which is often difficult to find in LMICs, and this new concept, which is very, very important, the transition where people are falling off after years of good care. And these are the issues, the backbone structures. Along with those, they've been taken down into the list you see on the bottom on the left side in these 6 different models, if you will, that you can take into. And those you see in the circular form, which you cannot read for each section. This one is colored blue for section 1, screening and surveillance. Thanks to Colette and her beautiful artistic work, each of these are visibly seen. And each of those pieces are then broken down, and these are the key bullet points, but then they expanded in the document. Friends, it's a circle. Notice that. You can come in anywhere in this circle and belong and participate. You may be in the service delivery infrastructure. You may be in the governance. You may be in the finance. You may be in the actual nuts and bolts of the workforce. Anywhere you join, you can strengthen the efforts is the way we try to design this works. Next slide, please. The beauty of this is that we can share quickly nowadays electronically, of course, like we're doing now. And we basically have to combine our resources. On the top right, you see all the various institutions that have participated and contributed. And basically, you know, that's a big, big powerhouse of wonderful people with great capabilities. And it's heartwarming to talk to all these people. And you'll recognize some of those logos. Some of you are in this group today, and that's where all this comes together. To me, the third point on the list is very important. Learn from each other. Having traveled the globe and worked in various parts, friends, we don't go there to teach. We go there to learn as well. There are people who do things a whole lot better than I can ever do. With the resources they have, they get great results, and I can learn from that, and I've done so. And that's what that is. This document gives us the avenue to learn from each other. And as you'll hear more and more, the NSOAPS idea from the Lancet Commission from 2015, using various NGOs. I initially had NSOAPS, NGOs, and no-nos, but I thought it was kind of a negative, so I didn't put the no-nos, I just put others, meaning there will be naysayers. There will be people who say, no, it can't be done, not in our neighborhood. No, 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 it's not for us, but we'll work with them. We'll help them see where we can learn from each other. And that gives us to the fifth bullet point, the success stories. What may work in Uganda may be different than Malawi, different than India, different than somewhere else. My friends, that's where we have to learn and build from each other. Say, hey, they did it, we can do it too. And friends, I keep mentioning 2021. These two documents that Key Park mentioned, this one came out in November, and the other document you'll be hearing came out in January. These are fresh. We'll reassess it. We'll reevaluate in a few years and see those 6 little cutouts. Those are all from the various pieces. You could be in the governance, you could be in the finance, you could be in the workforce, you can be in various pieces. Where each one of us feels comfortable, we can join the team, enhance the work. And I'll end with a simple analogy some of you heard before. It's like an anchor in the chain. I heard this when I was a paper boy in Houston when I was growing up. All the great things people do are wonderful, but if the actual newspaper didn't get to the person reading it, it was useless. If the document that we wrote and everything we did is academic, unless we deploy it and get people like you and others to use it to benefit the patients of the world. Thank you so much for your time.
Thank you so much, Dr. Patsapu. That was a great presentation. So I'll be introducing the next speaker, Dr. Nicolene Chisp. Dr. Chisp is a technical officer working in the Brain Health Unit within the Department of Mental Health and Substance Abuse at the WHO. In this role, she serves as the liaison between WHO and various neurological associations around the world. Prior to her role with the WHO, she worked with Johns Hopkins University, specializing in neuroimmunology, neuroinfectious disease, global neurology, and public health. Currently, she is assisting in the development of the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. This is an incredibly promising document, and today, Dr. Chisp is going to tell us a little bit more about this plan. So now I'll let her share her screen and get her presentation started.
Thank you very much. Is my screen showing?
Yep.
Yes, okay, wonderful. So good morning and good afternoon to everyone. It's a great pleasure to be here today to discuss the important issue of advocacy in global neurosurgery and to tell you a little bit more about the process by which we've developed the Intersectoral Global Action Plan on neurology, on epilepsy and other neurological disorders. I'm going to start with an overview of the process that led us up to where we are today. It started in November 2020 when the 73rd World Health Assembly adopted Resolution 7310, which requested the WHO Director General to develop an intersectoral global action plan in consultation with member states. We began the work by starting on an initial discussion paper between March and April of 2021. This was followed by formal virtual consultations with member states, United Nations agencies, and non-state actors, such as civil society, academic institutions, and private sector organizations. We then came up with the first draft of the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders after we had published the consolidated comments on the first discussion paper. We then began a web-based and virtual consultations on the first draft of the Intersectoral Global Action Plan. And again, once again, we published the consolidated comments that we received on this first draft. We then, in January, this past January of 2022, we submitted the revised draft to the 150th session of the WHO Executive Board. And this is where we are at the moment. We're very excited for this upcoming May. We're hoping that the action plan will be considered at the 75th World Health Assembly. You will see here an example of the various consultations that we had on the first draft of the action plan. So you will see we tried to include as large as a group of stakeholders as we possibly could. So for member states, we used all 6 WHO regions, and we had regional consultations with each of those stakeholders. We also included civil society, academic, and private sector consultations with up to 38 stakeholders. Very importantly, we had 37 individuals who have neurological disorders themselves or take care of people who do have neurological disorders as well. 19 member states submitted written comments, as well as a variety of different written comments that came from an entire spectrum of civil society, academic, and private sector consultations. So very importantly, we wanted to include people with neurological disorders and their carers as they are the ones who will be directly affected by this global action plan. All 6 WHO regions were represented. 37 of these individuals attended. Most of them had neurological disorders, and some of them were caregivers. Conditions that were represented included multiple sclerosis, Parkinson's disease, epilepsy, meningitis, encephalitis, migraine, post-COVID, Charcot-Marie-Tooth, Huntington, stroke, myasthenia, and many, many others. Overall, the draft was very well received by most stakeholders, and some of the comments that people gave us are here in this graphic. So the action plan, I could talk all day on the strategic objectives of the action plan. It is very, very comprehensive. It has 5 strategic objectives. Number 1 is to raise the prioritization and strengthen governance. Number 2 is to provide effective, timely, and responsive diagnosis, treatment, and care. Number 3 is to implement strategies for promotion and prevention of neurological disorders. Number 4 is to foster research and innovation and strengthen information systems. And finally, to strengthen the public health approach to epilepsy. Many of these are directly relevant to neurosurgery, particularly in low and middle income countries. And we are very excited to move forward and start the implementation of these objectives as fast as we can. So thank you very much for having me today. I look forward to the discussion.
Thank you, Nicolene. That was very, very interesting and insightful. It is a great honor for me to present the next panelist. Andrea Winkler is a neurologist and the co-director of the Center for Global Health at the Technical University of Munich. She is also founding director of the Center for Global Health at the University of Oslo, where she holds a full professorship in global health. She is co-chair of the Lancet One Health Commission, and she has been working closely with the neurology unit at the Department of Mental Health and Substance Abuse at the WHO, and was invited to give input to the Intersectoral Global Action Plan on Epilepsy and Other Neurological Disorders. She is also part of the Chisp advisory group and gave substantial input on these policy recommendations. And therefore, she sort of bridges these 2 major policy documents. Andrea, without further ado, we're all looking forward to listening to your presentation. The floor is yours.
Thanks a lot, Camilla, for this very nice introductory words. It seems I cannot share my screen. Let me see. Works now. No, I can still not share my screen. It worked before. It says host has deactivated the screen.
Eddie, will you help us share?
Dr. Winkler, I think you should be able to share now.
Yep, thank you. Can you see my screen? Yeah, okay. So again, Camilla, Key, Yogi, and all dear colleagues, thank you very much for this lovely invitation, the second actually in a row, and so happy that you take the GISPR forward also from the advocacy point of view. And as Yogi just said, I think the most important really now is to operationalize, to implement, and to move to action. And action and civil society is represented in my talk with the hands up. So they going to follow us throughout the talk. And I'm very happy that Nicoline already introduced the Global Action Plan, the Intersectoral Global Action Plan for epilepsy and other neurological disorders. This is just a stepwise approach that you can see here. And we had various documents along this process. There was this discussion paper that Nicolina mentioned. Very proud to say that my team and I were part of the discussion process. I think this was done in a very holistic, interdisciplinary, and very inclusive, equitable way, and needs to be highly commended. Also, that was already mentioned by Nicolina, but I just, the overall aims of the action, I just put in bold the really important statements, and potentially also those that are unusual. So here we don't start with burden of neurological disorders. I mean, it's also neurosurgical disorders, just by the way, but it's stigma, impact, and burden being represented by mortality, morbidity, and disability. Disability very often is neglected. And that not being enough, we also move forward, not just absence of disease, but also really well-being and quality of life, and not only the patients, but also the carers, the caregivers. There is not only emphasis on treatment, but also prevention, and other keywords are entry points and synergy. So basically, let's look what we have already. What could be entry points? Where could be synergies? For example, with non-communicable diseases at large. Lots is actually going on at the WHO level when it comes to non-communicable diseases at large, where the Intersectoral Global Action Plan on epilepsy and other neurological disorders is also integrated. Nicolina, please correct me if I'm wrong, but this is how I have viewed it and also read up on it just recently. The guiding principles are very important. People-centered primary health care, integrated approaches, evidence-based, a life course approach, intersectoral approach, empowerment of patients, but also caregivers, gender equity, and human rights. And human rights are really upfront. And this is also where I put the hands again, because this is where civil society and advocacy can come in rather easily, also with the other guiding principles, of course, but especially empowerment and equity, social injustice, etc. I think this is a good playing ground for civil society and advocacy. I think I can almost skip that, but important is that for the strategic objectives in that action plan that Nicolene has also introduced, is that policy and governance is also upfront. And actually within this objective, besides management, promotion, prevention, research, innovation, public health, is actually the integration of advocacy. So a whole objective and sub-objectives have been dedicated to advocacy. So this is where in the Global Action Plan, advocacy comes in. The Global Action Plan also had or has got a list of targets and indicators how these targets could be met. Again, we will find advocacy there. And it's a very ambitious aim. 100% of countries will have at least one function awareness campaign or advocacy program for neurological disorders by 2031. So this is a very clear target. And here you can see the indicators. Again, they're rather strict. This one you know already. But then the inventory is around the functioning and the systematic approach to those advocacy campaigns. So really something that is implemented. What does functioning mean in this context? It's financial resources need to be in place, program needs to be managed, evidence of progress needs to be documented. And last but not least, again, the equitable aspect, bringing in the vulnerable groups and having these campaigns, awareness raising campaigns at the population level, but not leaving anyone behind. I will not go through the whole thing. I will now come to the great Chisp. I was asked to sort of compare and see also where they're aligned and where there could be entry points from one another, those two documents, putting them side by side. Again, Yogi has already introduced the CHISPR, the various sections. So what I've done in my mini analysis, I've just put in the keyword advocacy, and advocacy popped up quite prominently in two sections. And these are the sections, of course, that are really amenable to advocacy, easy entry points, prevention and pre-hospital care, where advocacy groups have been mentioned explicitly. But it's not only that, it's throughout all these 6 sections, there have been, at least I was able to identify various entry points for advocacy. And I've just chosen a couple, 3 actually, on the first aim. And as I went through, there were many more. So for example, for the first aim, which is surveillance and epidemiology, it says that parents and caregivers need to be trained and included. It also says that we have to promote government funding of health research. Here is another entry point for advocacy, that this really happens. And again, to create policies favorable to promote NGO support. So NGOs can be viewed also as part of civil society. That's one thing, but to create policies for policies to be reinforced, advocacy is always needed. So in a nutshell, this GSPR really represents a great opportunity to enact some of the aims of the Global Action Plan very concretely at grassroots level for our 2 diseases, spina bifida and hydrocephalus. My second task was, and that was really a bit daunting, but I think there's still quite a lot of work to be done to see where there is already advocacy going on with regards to neurological and neurosurgical disorders, but in low and middle income countries. So I went through different websites and documents, and of course the World Federation of Neurology, they're doing great advocacy, mainly through teaching. The same goes for the World Federation of Neurosurgical Societies. They just had their World Congress in Bogota in Latin America. So that also, of course, contributes to advocacy. Then here, the World Brain Day with brain health for all, a very, very equitable approach. I've also looked because that is at the global level, right, the societies. I've also looked at the national societies, like the Asian one and the African Academy of Neurology. And I've also looked at even a society for neurosciences, so more basic science and basic research. Advocacy is mentioned somehow in some aims, but not really concrete enough. And this is most likely there are great initiatives that I'm not aware of, but then they are not really visible. So one thing is there are great initiatives, fantastic, but they also need to be visible. We have the EFNA that is very well known to you. It's the umbrella organization of the European patient organizations for neurology, and they are partnering with lots of other societies like the European Academy of Neurology, but also the NCD Alliance, etc. I think they are a great example how patient pressure groups and interest groups can get organized and then also be part of the enabling network. To cut a long story short, I think what a great success story, what I stumbled upon, but it's very well known, is of course the International League Against Epilepsy with their bureau and action. Amos will tell us more. He has been a great advocate for many, many years. I mean, over a decade almost. You have been advocating for this action, and we have also worked together, and I know what a great advocate you are, but they are really doing it. So they are a great example. They are on the ground and they are visible. And I just like this picture down here. So that's the IBE, the International Bureau for Epilepsy in Africa. And this picture is really lovely. So there is advocacy present, and I really hope we can do it for other neurological and neurosurgical diseases as well. I just wanted to lose some words, just a couple of more minutes on civil society. I know this is most likely not a very research oriented approach, but this is really what struck me throughout the years that I've been working in global health and global neurology. So civil society is often referred as the third sector, besides the private sector and the public sector. They can include various stakeholders and different organizations. NGOs and academia can be parts. Others say they are a separate sector. Democracy is a conditio sine qua non, but at the same time, the civil society, they reinforce democracy. They can put a lot of pressure on governments and the private sector, and they are crucial for advocacy. Climate change, COVID-19 has really been a catalyst for civil societies. They have become rather powerful through also new technologies and innovation. And the new buzzwords that we use also need to be enacted. Buzzwords like transdisciplinarity, co-creation, co-design, and empowerment of communities. There shouldn't just be words, but we really need to act on them. This is my final 2 slides, and it's just an example where advocacy is working really well. It's the NCD community at large. So they usually approach an NCD problem by stating on NCD issue, by stating the problem. Here you can see basically we are off track. We are not going to reach our SDG target 3.4 if we continue like this. Then they identify the solutions. So risk factor reduction and primary strengthening of primary health care. They create best bets. So what can be implemented, what works on the ground. And then here on the bottom right corner, you can see the various advocacy entry points globally, locally, but also through academia. And at the end of the day, every health issue is a whole of government, but also a whole of society approach. And this has been shown very nicely, and I will not dwell on it because I'm over time. Within the NCD sector, through the WHO, and they include, of course, neurology, but neurology is also a large topic part, but joining forces would be just so critical. And then now closing the loop again, coming back to the brain health unit at WHO, of which Nicoline, she's is part. It's up to us as academics, up to us as advocates to support, to publish, to write, and to raise our voices in support. Thank you very much.
Thank you, Dr. Winkler. That was a very great talk. Next, we have Action Amos. Action is from Malawi and is a person with epilepsy. He has held various leadership positions, both locally and internationally. Action is currently the Vice President of the International Bureau of Epilepsy in Africa, a board director for the African Disability Alliance, a co-founding chairperson of the National Epilepsy Association, Epilepsy Movers, and a founding trustee of the Mental Health Users and Carers Association. In addition, Action is also a member of the Pan-African Network for Persons with Psychosocial Disabilities, and he has worked with the WHO and the UN for various initiatives. If you lost count of all the organizations that Action is involved with, I don't blame you. I could probably talk about his incredible bio for another hour, but I'll pause now to let Action share his slides and begin his talk.
Thank you for that introduction. I get humbled when we get into discussions such as this, and something that personally affects me as a person with epilepsy. And it's interesting, and thanking all the organizers for this initiative that we talk about the different global action plans that we need to see implemented. And mainly what brings us to such discussions is the fear of not being able to the fear of having good documents but less implementation. So I will share some of our fears as well as International Bureau of Epilepsy Africa. Just briefly to talk about the International Bureau of Epilepsy, and especially with the focus in Africa, our vision is to see a society which values diversity and respects equality and realizes the full potential of persons with epilepsy, so that they can also be able to contribute to a better world. So what do we then do, which is our mission? So we advance the rights of persons with epilepsy with a united voice, utilizing international legal instruments such as the IGAP we're talking about, the UN conventions, different conventions that we can talk about, those that apply to children, those that apply to women. So we are a network of 27 members, and we are represented in 24 specific countries. In this network, you will see those in red, countries that are currently being funded by IB Africa with a small fund. And this small fund, again, is supporting advocates around International Global Action Plan, and we've just released the first batch of funds to this. So they're like 2 weeks, 3 weeks into their projects. Then those in green are our trend setters.
Action, we can't see your second slide. You're still on the first.
Okay.
Sorry.
If I do this.
No.
Okay. Are you able to see the second one?
No, we're seeing the first one.
The first one. Okay, let me see. Here.
No.
No, okay. Okay, I'm not so sure my slide controls here. Okay, I'll stop sharing, then start again.
Action, if you want,
also share for you.
I can also share your slides.
Oh, okay, thanks. All right, that would be great if you can share for me. Okay, thanks, Eddie. Okay, so we can move on to that one. So the ones in red I had already mentioned are the countries that have been supported with a small fund, and the ones in green, there are 4 of them: South Africa, Eswatini, Kenya, and Mauritius. These we are calling them trend setters or trail blazers. These 4 countries have been funded to come up with an adoption model plan on how the International Global Action Plan can be adopted. So what would the other countries in Africa, how would they do? So there are different dynamics. Some countries are working at national level, some are working at local level, at district level, working with counties. They're also going to come up with an intersectoral global action monitoring plan model. These 4, again, are going to come up with an information hub, shared information hub. Within these countries, we are going to draw a regional steering committee that is going to be focusing specifically on the intersectoral global action plan. We have governments that are part of this project. We have national human rights institutions. We have other neurological disorders. We're not just talking about epilepsy here for this project. We can move on, Eddie. Just the excitement that we have, that everyone has, is the increased space that now we are currently enjoying, especially with the coming in of the intersectoral global action plan on epilepsy and neurological disorders. It has broadened our space where we can work. But this is just in addition to other frameworks that were already there. We have the 2030 agenda that has got good indicators around disability, good indicators around health that again can speak to epilepsy and neurological disorders. We have the WHO Disability Inclusion Strategy that is being discussed. Currently, consultations are going on. Again, we've participated as groups of epilepsy and other neurological disorders. Then we have some guidelines on humanitarian action. We can talk about COVID currently. We can talk about what's happening in Ukraine, but focusing on Africa issues, challenges, humanitarian challenges. Again, we're trying to advocate as much as we can. You'll be surprised that on the package of WHO essential medicines in a humanitarian settings, medication, anti-seizure medication are not listed, are not part of that. So this is one. So there's quite some excitement on the space that we can work with in this time that we are. But now let's talk about the challenges and the fears that most of us have. We can move on, Eddie. Okay, so what are the potential challenges? These potential challenges, we are drawing them from other global action plans that are there in place. Andrea just talked about the NCD, where she talked about the likelihood of missing the targets for the Sustainable Development Goals. We have a good document, we have good action plan, roadmap around NCDs. But what makes such good documents, such well thought around not being implemented? Just like the fear that we have for the Global Action Plan, of which we're all hoping that that is not going to be the case, because we are all geared up to ensure that we see, we translate whatever we've done into action. One is the lack of in-depth understanding of the IGA principles and obligations. Andrea highlighted these, as well as Nicolene also highlighted some of the key principles that are there. The one that touches my heart is the one to do with mainly a people-centered approach. That really touches my heart as a person with epilepsy. But there are also obligations that are there for civil society, for governments, member states, for service providers, and so forth. If we do not understand this very well, we are likely to miss the goal or the target. Gaps in technical capacity, that again can be. We might work and partially fulfill and achieve what we want to achieve. One indicator is talking about 100%, all the countries just having one neurological disorder campaign. We can miss that if we have gaps in technical capacity, lack of data. I'm happy that WHO currently has put in place a study that is going to start soon. They've just put a call for consultants to be engaged in that, where we are looking at epilepsy and other neurological disorders, the current status of epilepsy. That again is going to give us a good baseline within Africa. Insufficient financial commitments. These documents, when they are passed, they are adopted, they are ratified. At times, governments do not even support such arrangements. That again can be our challenge. Then another challenge that we have seen and learned from past experiences with other movements is the lack of meaningful involvement of the civil society. Just as was highlighted by Andrea, that there are spaces where civil society is key and crucial in ensuring that the implementation is going to be what we want and what we see. So if organizations of persons with epilepsy or organizations of persons with neurological disorders are not meaningfully involved, we can have quite some challenges, because they bring in another leg of expertise into this work. Yes, we're talking about epilepsy as a mental, as a healthy issue, but also there are other issues that are concerned with the same. Then another fear is that of insufficient or inadequate strategies to invest in the capacity, again, of these organizations or their representatives. So these are just some of the fears that we can have in terms of, that can lead to a non-successful. We come to 2030 and look back, review, and find that we have not done much. We can move on. So as IB Africa, yeah, we can move to the next slide. So as IB Africa, we've come up with a project, making epilepsy a health priority project. This, we started it last year, and now we are in the second phase. Pillar 1 is looking at legislative and policy frameworks. How can we ensure that the policy frameworks that we have, as you know, we are not advocating for coming up with just national epilepsy plans. We are even saying, where we cannot be able to come up with a standalone plan or a epilepsy and neurological disorders plan, there is no need for having just that standalone plan. We can even use other plans that are already there. We have NCDs, we have mental health, different plans that are there. What are the gaps that are in those other plans that we can see the mainstreaming of these other conditions, but also speaking to the intersectional global action plan? We are starting an IB Academy where we will be equipping and strengthening advocates. And I'm glad to say that EB International has given us a green light, and this IB Academy is going to be established in Africa. We also have a project where we're funding small organizations in capacity building. Well, I will not talk much about each of these pillars. Let's move on. I had summarized each of them. We can move on. So in pillar number 3, which is building technical capacity of epilepsy advocates. Okay, we can, no, we're starting with pillar number 3. Okay, thank you. So here we intend to grow the number of advocates in the region, in the African region. So this is talking to the training and the small funds that we have given to 5 countries. But not only that, we're also going to give a bursary to come up with champions in different countries who will be supporting that. But all this will be talking to the intersectional global action plan. You can move on. Okay, so pillar 1, as I've mentioned, its aim is to strengthen the capacity of chapters to influence health policymakers to adopt and implement the WHO IGAP. Okay, let's move on to the last pillar, which is pillar number 2. So here we are investing towards IGAP advocates training, and we want to come up with a sectorial flagship of initiatives. We're looking at issues to do with education, social protection, livelihoods, as well as health, but not forgetting the biggest elephant in the room, especially in the African region, stigma, and also looking at support services that are provided, including access to medication. So I think we're getting to the end, to the very end, the last slide. So mine is just to thank you for your attention, and looking forward to a fruitful discussion. Thank you.
Thank you so much. Actually, that was a truly amazing talk. I learned so much. Now I'm going to introduce our next panelist. Hodan Abdi is a rising fourth-year medical student who has spent this year at the program in global surgery and social change doing work with Key Park. Hodan is a Somali Ethiopian who immigrated to the USA with her family in 2013, and she is currently at the University of Minnesota Medical School. She will be applying to neurosurgery and is passionate about contributing to global neurosurgery. Hodan, I am thrilled to have you on board, and I'm excited to hear you speak about the importance of a civil society in advocacy from a perspective of a medical student and our new generation of excellent medical physicians. Welcome, Hodan.
Thank you so much. Can you hear me? Thank you so much, Camilla, for the kind introduction, and thank you all for inviting me here. I feel like I'm out of place with all of the experts here, and it was great learning about all of the work that you guys are doing. So today I would like to kind of share my perspective as a medical student. And I feel like as a future physician, it's important for us to engage in advocacy for our patients at the clinic, locally and internationally. And I have been learning a lot about the work of advocacy from my mentor, Dr. Berg, who has been a great mentor to me in the past year, and learning about ways to advocate for our patients and also learning about the disparities that exist. So here we have this work that was done by Dr. Berg. So it's showing a number of the neurological surgery that's done each year and in different regions. So if you see the yellow and the red in African region, it shows that there's still there are not enough neurosurgeons to meet the needs of these populations. And Dr. Berg's their work, they estimated that we need 5 million surgical cases are unmet each year, and we need 23,000 additional neurosurgeons to be trained. So the disparities is very big. So what can we do? We can educate more neurosurgeons, but we can also do other things, advocate for these patients and these people who are lacking neurosurgical cares at the system level. So next, I would like to introduce some of the organizations that I was able to learn during my year last year. So the first one is called Injury Prevention Initiative for Africa. So this is, we know trauma is a very significant problem, especially in low and middle income countries. 90% of trauma is from the low and middle income countries, while the literature, 10% of literature related to trauma comes from low and middle income countries. So there are still disparities there. And trauma is still a significant cause of mortality and morbidity in LMIC countries. So Injury Prevention for Africa is their role is to kind of address the high burden of injuries and promote evidence-based interventions. They are also doing research to kind of understand what are ways we can prevent trauma, and also they are working to create real solutions to keep these populations safe. So here is this picture from Tikurambi's hospital. Last year, I was one of the attendees, and here we have a representative from different hospitals from Addis Ababa, in Ethiopia, and each of the hospitals were kind of presenting like their data of all of the patients that they are seeing and the trauma, the patient that they are seeing, and stuff that can be preventable, especially road traffic accidents is very common. And the lady who's presenting, she's a representative from the Minister of Health of Ethiopia, and she presents their strategic plan for surgical care. And she also made sure that she will take the information that we share with her, and they will try to incorporate these preventative measures into their strategic plan. So this was our first workshop, and many more to come. It's really exciting, the work that they are doing. They're working on kind of incorporating helmet use and also safe construction sites for workers, which is another major problem for injuries, especially in trauma in Ethiopia. Next, I would like to highlight the work of Global Alliance for Prevention of Spinal bifida. Spinal bifida and neural tube defects are also another big problem, especially in Ethiopia and low and middle income countries. So this group is co-funded by G4 Alliance. G4 Alliance are a global alliance for surgical obstetric trauma and anesthesia care. They are an advocacy coalition, and they have 60 members. Members include academic institutions, healthcare providers, federations, and non-other governmental organizations. So GASPI, which is Global Alliance for Prevention of Spinal bifida, are working hard to promote folate fortification. We know that 75% of spinal bifida cases could be prevented with folate fortification. And many of the countries that have this problem, they still do not implement folate. So in the coming month in May at the World Health Summit, they will present this resolution that's going to highlight the importance of folate fortification, and they will present the data that we have and evidence-based data. So hopefully it will go through. And then this group is also currently working with Ukrainian doctors to collect baby foods for Ukrainian children and other health wound care supplies. And they have written a letter to Nestle to work and lead this effort to donate foods for Ukrainian children who are impacted by the war. So the next group that I have been fortunate to be part of is the Global Neurosurgery Committee. This is a committee under the World Federation of Neurosurgery. So they are a group of doctors, trainees, residents, and medical students from LMIC. 50% of them are from LMIC, and the rest are from the high-income countries. So we are working hard to kind of do research and advocate different issues that come up. And this group have been leading a lot of the work that has been done in global neurosurgery, special LMIC work, highlighting many issues that are affecting patients and populations in LMIC. So this is photo from Colombia, Bogota a few weeks ago, and we had many medical students attended this event, and they presented the work that they are doing, especially to not just clinical work, but also advocacy work, and that we are involved in. I cannot wait to see what we can do in the future. And it's important, as a med students, we have the time and the resources, and kind of getting engaged early on will help us advocate for our patients and for our people. Thank you all.
Thanks, Hodan. That was a great talk. Our next speaker is Tori Robinson. Tori is a speaker, podcaster, YouTuber, and patient representative for multiple organizations as a person with epilepsy. Having had refractory epilepsy for most of her life, Tori decided to devote her career to bridging the gap between clinicians, researchers, families, and governments. Today, Tori will share her story and experiences as a patient advocate.
Thank you very much for having me today. I really appreciate it, and I'm feeling rather half intimidated by hearing such wonderful speakers. And as a patient with epilepsy, it's extra inspiring for me. So thank you very, very much. Can you see my slide yet? Just want to check.
Can't see your slides yet, Tori.
You can't yet. Okay, 1 second. Sorry, hang on. There we go. Can you see my slide? And my crazy smile? Okay, great, great. All right, 2 seconds. Sorry, I'm having a bit of a problem. Okay, great. So I'm just going to go through just a bit of my background and just to make you, or hopefully get you to understand why I'm so passionate about what I do in my work and speaking with people such as yourselves to make a positive difference to the lives of people affected by the epilepsies around the world, particularly in low to middle income countries. So as you can see by the title, temporal sclerosis, that is my situation. I had febrile status epilepticus when I was a baby. Maybe that was the cause of the temporal sclerosis, we're not sure. And I remember my first seizure when I was about 6 years old, and I almost walked into the classroom naked. Luckily, I didn't do that because that might have affected my life rather significantly. And then I was diagnosed when I was 10, and my parents noticed I was behaving slightly differently to an average child, should we say. And I was having focal seizures at that time, and only focal seizures. So focal partial awareness and absent seizures. And then I had my first tonic-clonic, I believe, when I was about 14, and I was out skiing and I fell asleep in the snow, and I was very relaxed. It freaked other people out, but I was kind of used to having seizures. So I didn't really get, and this is one of the benefits, one might say, of having it from a younger age, is that it's kind of normal to me, which doesn't sound right in retrospect, but that's the way things work. And then I jump a few decades or a couple of decades. My epilepsy, which was refractory, was just getting worse and worse. So I was going on to have secondary generalized tonic-clonic seizures. I would have injuries. I fell on a railway line during rush hour. Luckily, obviously, I didn't get run over. I fell in the middle of the road off my bike, and I almost got run over there. I very badly actually, requiring 2 surgeries, fractured my left clavicle. And all the while, I'm very, very conscious that I'm saying this like, oh my goodness, these things happened. But here I am in the UK, I'm based in London, and I can get the help that I need despite that all happening. And I'm very, very aware that I would be dead, literally dead, without the medical help that I have had today. And I'm currently, you know, you're of a certain age when you forget your own age. I'm 41 now. So I would certainly be dead if I hadn't have had this help. Right, next slide. So as I mentioned, refractory epilepsy, quality of life, do those things go together in one sentence? I just wanted to point out that, you know, epilepsy and seizures are not solely about the seizures. They have very often a physical impact on a person. The seizures themselves, yes, but also the impact, if we're lucky enough to have access to anti-seizure medications and other medications for comorbidities, which often come with the epilepsies. The cognitive impact of the drugs, the seizures, but also the psychiatric comorbidities that often come with this disease. Obviously, that can affect your attention span, your attention to detail, as I mentioned, your cognitive abilities, and just whether you want to get up in the morning or not. And as somebody who's had, I'll explain a bit in a minute, but psychiatric comorbidities my whole life, it's been a real issue for me, as with many patients. Now, this is going to look really cold, but I put a picture of a skull here because, as with so many other people all over the world, with worsening epilepsy and continuing epilepsy and injuries, well, I'd already explained to you, I was had injuries, but my risk of death was literally going through the roof, as was my risk of SUDEP. So sudden unexpected death by epilepsy, where for people who aren't aware, I'm sure most of you are, but sudden unexpected death in epilepsy is far more common in people who have tonic-clonic seizures and those who have refractory epilepsy. And actually, according to a paper which I read recently, my likelihood of dying of SUDEP prior to surgery was about 20% per year. So yeah, I had temporal lobe resection, very lucky to be suitable for that. And of course, as I mentioned, to actually have access to the National Health Service. Even on this little island in the UK, I did go over 2 decades with refractory epilepsy, which is considered over here to be totally unacceptable. Which again makes me think of low to middle income countries where it's not an option much of the time at all. So just the history here, I would have, I had some ambulatory EEGs, but I've also had video telemetry. That's me looking hot as anything in after my surgery. And before having my stitches out, I had cerebrospinal fluid leak, but that was sorted out. Again, I'm very lucky. And then I put this picture here, which looks awful. It's a black box with drugs, and that's because I overdosed multiple times and ended up in psychiatric hospital. I would rather have seizures every day than have psychiatric comorbidities, as is the case for many patients who rarely get the opportunity, I think, to actually say that, but it is very often the case. Hence, I've put this sort of little graph here to say how important the roles of, oh gosh, sorry, I'll go back 1 second. The roles of different clinicians are crucial for effective care of patients. Obviously, we have to prioritize in low to middle income countries at present, but ideally, we would have obviously a general practitioner, an epileptologist or a neurologist specializing in the epilepsies, an epilepsy nurse who you can actually speak to for more than 10 minutes once a year and understands the day-to-day things for somebody with epilepsy. Obviously, the person doing the EEG, neurophysiologist, if you're lucky enough, a neurosurgeon, which is why you guys are brilliant. But then also really important, I think I've pointed out, access to a psychiatrist or neuropsychiatrist. Personally, I take, yes, antidepressants, venlafaxine, but I'm also on antipsychotic, quetiapine, but actually to help me sleep, because we know that without sleep, a person is much more likely to have seizures and, of course, increase their risk of injury and death. And then therapists for the common psychiatric comorbidities, social workers if person is not able to work at that time, and for those suitable for a ketogenic diet, a dietitian comes in pretty handy. Righty-ho. So just say to myself, post-surgery, this is a really, really boring slide, but just to get the points across. As for many patients, we can have surgery for epilepsies or other diseases, other neurological diseases, but it's important to note that surgery doesn't equal necessarily cure. So in my case, I've had 7 tonic-clonics post-surgery. I have a focal so once every 2 to 4 months. I've also experienced status epilepticus again this year, which was really weird and pretty frightening. I have nocturnal seizures that I'm aware of, and I see these wonderful professionals pretty regularly. So the neurologist, neuropsychiatrist, which I strongly believe everybody around the world is entitled to see for quality of life. It's not just about how long we live, it's about the quality of time that we have on this planet that matters. So today, I made this, I came to that point in my life, right, where, and many of us have had it, you don't have to, you know, almost die to have it, but you know, you think, I want to make a difference, what can I actually do? And I'd grown up wanting to be a commercial pilot, a dentist or a surgeon, and obviously with epilepsy, that's not going to happen. So after surgery, I decided to start a website, and where it was a bit of a moan or a blog intended to be educational. Anyway, this took off completely unplanned. And this is Epilepsy Sparks. And over the past couple of years, I've been working with an incredible organization called Protola Global Health Consulting, who specialize in training clinicians around the world regarding the epilepsies. I thought that was a good image of the world. Really, we should be working together ideally. Now, together, with many organizations and also clinicians, scientists, researchers, basically I'm interviewing these people on my podcast and on my YouTube channel to bridge that unnecessary cultural, amongst many countries, gap between us lot. We're all of the same species as far as I'm aware. So patients, clinicians, scientists, and researchers, and we should be understanding what is going on behind the scenes. And what's going on behind the scenes, this fabulous research that you guys do, we want to know about it. Patients, families want to know about it. And it doesn't have to mean that it's research that benefits the patients directly. It could be we need to let them know that this isn't going to help you today, but maybe 20 years in the future, this could help somebody. And that gives us realistic hope. And when we think about people who have refractory diseases, especially the epilepsies, sometimes that's all we need to keep us going from day to day. It's not just about the seizures, it's not just about the drugs, but it's having realistic hope. And that's what matters. And just to give you some perspective, I reach out to countries from around the world, clinicians at the moment from Ukraine. We're on our 5th episode. It's going to be released today with a clinician who's actually born in Ukraine, moved to the States, but we've got people who are actually in Ukraine at the moment as well. And from South America, from Asia, from Africa, all around the country, plus the ones who maybe don't deserve so much attention at the moment, but in more sort of wealthy countries. But I do strongly believe that through effective communication between all of us being people, wherever they are in the hierarchy of medicine, research, and treatment, patient treatment, we can achieve so much more. And I do, as a sort of ending point, I do highly recommend everybody checks out Pretola Global Health Consulting, which is led by a person called Talua Lanyon, who is she is a learning disabilities nurse specializing in epilepsy and is absolutely a queen. So do check her out. And I welcome any questions at all from anybody here today. Thank you for listening.
Wow, that was just amazing, Tori. Thank you so much. It has been wonderful to listen to all of your talks. I have learned so much. The chat has been lively while we've heard the presentations. I saw there was one comment or question from Adam, and you said you could address that question yourself. Are you comfortable taking the mic and asking the question, Adam? Can't. Okay, so Jeff, okay, while we wait for that question, we can have Jeff's comments. Go ahead, Jeff.
Thank you. This was spectacular. The first comment I would make is that nobody should feel self-conscious about presenting amidst others, because everybody brings something that the others don't know. I don't know, epilepsy and spina bifida are my 2 great academic loves in academic surgery in the career that I've chosen, but I don't know, I've talked to lots of patients, but I don't know what it's like. And so sharing that story is always worthwhile. And we can't hear it too many times. It never gets old. It never gets redundant, because your story is a little different from somebody else's. So Tori, I congratulate you on using your voice, using your platform that you've built to really make it better. While I must confess, while you were wrapping up, I was cheating and using my phone to pull up your YouTube talk, and was working on subscribing. But so, I mean, those are the types of things. All right, so the point I wanted to make is that the communities of professionals and what you all collectively called civil society bounce off of one another in a markedly effective means. You bring things that we can't. You have energy, immediacy, traction in the political process, lots of numbers, people that can get on the phone and call policymakers. Our time is very spoken for. You have tremendous power. We can bring information, you can bring passion and energy. And this is truly a, 2 + 3 = 10 scenario, and then 10 + 10 = 100 scenario. And I think that that's to be developed and applauded. And I'll stop there, because there are others who have things to say.
Thank you, Jeff. Thanks so much. Yogi, you wanted to say something?
Yes, please. Thank you. One of the advantages of being old, as you introduced me, an expert, means I made the same mistakes for at least 20 years. Friends, I see a lot of young, beautiful minds, and I most importantly see people who are non-medical, who have tremendous expertise and wealth. You have knowledge, we have different knowledge, you have knowledge of a wonderful type. Those of you who have not done it, please reach out to the people like Action and all the others we see here. I have gone through, and people like Key, and I'll tell you, take a patient with you on the stage when you give a lecture. Your lecture will be 5 to 10 times better. The audience attention is that much more, and the amount of information you convey is that much more powerful. I've been on the stage with my spinal bifida kids. I've been on the stage with my head injury patients. I called the parents of the Spinal Bifida Association before I gave an oration. Their perspective, their views, their problems, their ideas and hopes make my voice more clear, make my message much more pointed. Here, I heard wonderful things. Most importantly, this is what this group is about. We need to hold hands in a way that we can enhance knowledge that we have with abilities that we've not yet put to use. I humbly implore all of you who have not yet raised your hand to join us, teach me how to do a better job on behalf of the GNC, on behalf of the Federation of International Education in Neurological Surgery, on behalf of International Society of Pediatric Neurosurgery, and all the other things I do. I can do better with your guidance and help. Thanks.
Thank you so much, Yogi. I think we have Adam on the call now. Is that true, Adam?
Yes, I'm right here. Thank you so much for this opportunity. As you have mentioned, my name is Adam. I live in the UK, originally from Gambia. So I am really, what should I say? This opportunity here means a lot. I am a person who continue to be affected by epilepsy. My son lives with epilepsy in the UK, and growing up, my brother in the Gambia lives with epilepsy. So he has never been diagnosed. Up to today, he's 45 years old and still on carbamazepine, but has lost the use of his legs, doesn't communicate that much, but he was born normal. So my question is, yes, we can advocate, because obviously we know in lower middle income countries, people don't know about epilepsy that much. And I really applaud the work that IB are doing. And Tulu, I work closely with them. They do support our organization in the Gambia a lot. So yes, we can advocate. For my experience, commemorating International Epilepsy Day in the Gambia, we went out to the communities, talked about epilepsy, encourage people to seek medical care. But the problem we had was, yes, all these people were like, okay, where can we go? Attended the hospital, but we didn't have resources in terms of diagnostic tools, in terms of medication. Some are on medication. I received a call yesterday that carbamazepine is actually scarce in Gambia at the moment. So going out to advocate with professionals will make a very big difference. I do agree. But I believe when it comes to epilepsy, it has to be everything together. A holistic approach is needed. And this is where we need support from organizations like yourself. So I know you guys are the experts. So my question is, how do we put all of these together to make the impact that is required, that is needed to make a difference in the lives of people with epilepsy, especially in lower middle income countries?
Thank you, Adam. Anyone wants to answer Adam's very interesting and relevant question from the panel? Action.
Could you repeat it?
Okay, thank you, Adam, for that question. Where as persons with epilepsy, at times we also in that dilemma that you have mentioned, where demand is created. We bring people out of the shadows, but the supply side is still found wanting. So you get people out, but then the services, access to medication is not available. You advocate for, good plans and so forth, but then the supply side. So I think that's where now this intersectoral global action plan comes into play, because it's bringing us all together, where it's not only talking about the demand side, but also the supply side. So there is really, as Jeff mentioned, and Jog, that we need to hold each other's hand and work together, so that these discrepancies that have been there for years, because we can keep on advocating, talking, but still, hitting the walls. In the 4 countries that I mentioned, Kenya, Eswatini, South Africa, and the other, what we have done, instead of taking governments as just duty bearers, we have actually brought them into the projects where we are talking about adopting the intersectoral global action. They are partners in the project. They are just not like, we are just there on the table and they are on the other side, but we are there together. We're developing, when I mentioned about the models and whatever, they are also involved hands-on, because we want to demonstrate, that kind of partnership where, the demand side and the supply side work together and, look at initiatives in country on how they can resolve. You find that I can give an example of my country, Malawi. We have had cases where, medication expires while they are in the shelf of the central medical stores. It's not reaching where it's supposed to be reaching. Why? Because, the education is not there, the hospitals are not, taking them on time and so forth. So this intersectoral, this collaboration, I think it's quite key, so that, we address some of these gaps that are there. Thank you.
Thank you so much, Action. I see Nicolina's hand is up.
To follow up on what Action was saying, he's absolutely correct that medication access and medication supplies are extremely important on a very, very basic level. Just getting people the medication that they need so that they can be stable and move forward with their lives is very important. And it is something that is an integral part of the action plan that we are currently working on and hoping to start implementing on a much larger scale in the countries that need it. But also I wanted to mention that civil society has incredible power in that they're able to put pressure on their governments. So the action plan would not be here right now if the governments and member states had not asked us to do this. And the reason they asked us to put together the intersectoral global action plan is because civil society was putting pressure on the government. So there is a tremendous amount of power in patient advocacy to their governments, and I think our action plan is a living testament to that.
Absolutely. Andrea, you go ahead.
Yeah, I just would like to add that we also, what we have now to really engage civil society, and I couldn't agree more with what was said by Action and by Nicoline just now, but also what we have now recently is really the innovation, the technology. So the connection that we enjoy, the digital literacy that is at times much more advanced actually in low and middle income countries, Action, right? I mean, I just remember 10 years ago when we worked together in Malawi, I think you have already used your electronic money transfer that I just didn't know what that was. And even now when we go there, I mean, people are very digital literate. Of course, there is a divide between urban and rural, but the same goes for patients and their relatives and advocacy groups, is to use those new tools to connect. And that is also it's one of the powerhouses that we have to make civil society more visible Because when I did my searches, I mean, I'm sure there's lots going on the ground, but it's just not visible. And it's about getting this visibility by using also the new technology. And there's also a new concept, which is dubbed citizen science. And I think that is also something that is really interesting, where we can bring in patients and relatives, but also the healthcare workers, of course, but especially those affected in helping with collecting data. So citizen science is really it's actually not that new, but something that could help making civil society even stronger and contributing to evidence, research, and innovation, and then putting pressure on governments to enforce certain policies and legislation. Thank you.
Thank you. Wow, we could just go on for hours. In the interest of time, I have one last comment or question, and then I think Key should wrap up so that we can finalize in time. So I would goes to Andrea or Nicolina. If you could comment on how we together can work using epilepsy as a model for other diseases such as spina bifida or hydrocephalus or head injuries. If one of you could comment on that.
You want to go first, Nicolene?
Please go ahead, Andrea. I can follow up, no problem.
I mean, you're absolutely right, Camilla, that a lot, but then Nicolene can comment on this. This advocacy around, and of course action, this advocacy around epilepsy hasn't sprung up overnight. I mean, that has been one of the diseases that has been advocated for the longest, I would say. But please, Nicolene, correct me if I'm wrong, through the WHO and of course the country offices and action, please come in. So it is also a matter of time. It is to use what we have learned. And I think what we have learned is that we need people like Action at grassroots, like Tori. We also need Hodan, who have all these inspirations moving forward, and then applying what we have learned, and now even having more powerful tools to other pressing diseases. That epilepsy has been quoted first in the intersectoral action plan is based on history in terms of that this is really the best examined disease and best implemented disease by WHO throughout decades. And please, again, Nicolene, come in. And it is just paving the way for us to follow and use the lessons learned. Thank you.
Thank you, Andrea. You want to give a last comment to that, Nicolene?
So absolutely. So to add on to what Andrea was saying, so epilepsy is the absolute perfect condition to use as a pathfinder disease. I mean, what do you need? You need a diagnosis, you need a neurological workforce, you need scanning capabilities, you need neurosurgical intervention capabilities, you need medication access, you need stigma and discrimination to be addressed. There are so many issues within epilepsy that can forge the path forward in low and middle income countries in order to gain, in order to give back to other neurological disorders. And so epilepsy is a very, very important condition, and it is a pathfinder within the action plan for other neurological conditions.
Thank you. Epilepsy as a pathfinder for other neurological conditions. Wonderful. I think it's 10:30, and I would like Key to just wrap up our session. And before I do that, I want to thank you everyone on my behalf for participating. It has been wonderful to spend this morning with you.
Yeah, I just want to say thank you for all the panelists for incredibly inspiring talks, and all the participants for this discussion. I feel it's not just the coffee, I know it, because I feel so much more excited now than before I started. And I think Tori hit the nail on the head. It's a sense of hope. Bring everybody here together in one place and talking about for the same objective, right? Which is we want improved care for people with neurological conditions, and not just medical care or neurosurgical care, but really a holistic care. And I'm just full of hope. And I think Jeff also gave a great visual. It's by working together, whether we're in academia and we do research and we publish, and then we amplify it through civil society, and we support our work through professional networks, the work that WHO is doing, the Global Action Plan, because it is a political process, right? So I'm just really encouraged by everyone. I think we should start really thinking about a global alliance for neurological disorders, and and a nominate action as the new, is the ED. And if we can make that happen as a result of this webinar, I can wish for nothing more. So thank you everybody for this wonderful webinar, and have a great day. Thank you.
Thank you and bye.
Thanks, everyone. Wonderful session.
Thank you, everybody. Great to meet you. Bye.
Thank you.